Question 1. What factors determine the selection of an optimal neuroprotective strategy in the acute phase of ischemic stroke, considering the need to balance potential benefits against risks and the current state of evidence-based practice as recognized by the American Board of Psychiatry and Neurology Subspecialty in Neurocritical Care? Option A. The patient's specific stroke etiology, the time since symptom onset, the extent of ischemic penumbra identified on neuroimaging, and the presence of contraindications to specific agents, all within the framework of current evidence-based guidelines and expert consensus. Option B. The availability of novel, investigational neuroprotective agents that have shown promising preliminary results in preclinical studies, regardless of their proven efficacy or safety profile in human clinical trials. Option C. The personal preference of the treating neurointensivist based on their prior experience with specific agents, without necessarily consulting recent clinical trial data or established treatment protocols. Option D. The patient's insurance coverage and the cost-effectiveness of different neuroprotective therapies, prioritizing those that are most financially advantageous for the healthcare institution. Correct answer is A. The patient's specific stroke etiology, the time since symptom onset, the extent of ischemic penumbra identified on neuroimaging, and the presence of contraindications to specific agents, all within the framework of current evidence-based guidelines and expert consensus. Explanation. This scenario is professionally challenging because the optimal neuroprotective strategy in acute ischemic stroke is a dynamic and evolving field, requiring clinicians to balance established guidelines with emerging evidence and individual patient factors. The decision-making process is complicated by the potential for both benefit and harm from various interventions, necessitating a nuanced approach that prioritizes patient safety and evidence-based practice. Careful judgment is required to avoid premature adoption of unproven therapies or the omission of potentially beneficial ones. The correct approach represents best professional practice because it aligns with the principles of evidence-based medicine and patient-centered care, as emphasized by the American Board of Psychiatry and Neurology (APN) and its subspecialty certifications. This approach involves a comprehensive assessment of the patient's clinical status, the specific stroke characteristics, and the available evidence supporting different neuroprotective agents. Adherence to established guidelines, such as those from the American Heart Association/American Stroke Association, is paramount. Furthermore, considering the patient's overall condition, comorbidities, and potential for adverse effects ensures that the chosen strategy is both effective and safe, reflecting the ethical obligation to do no harm. An incorrect approach would be to solely rely on anecdotal evidence or personal experience without consulting current, high-quality research and established clinical guidelines. This failure to adhere to evidence-based practice is a direct violation of professional standards and could lead to suboptimal patient outcomes. Another incorrect approach would be to implement a neuroprotective strategy without a thorough understanding of its mechanism of action, potential contraindications, or documented efficacy in the specific clinical context. This demonstrates a lack of due diligence and a disregard for the rigorous scientific validation required for medical interventions. A third incorrect approach would be to prioritize a novel or experimental therapy over a proven intervention without a clear scientific rationale or institutional approval, potentially exposing the patient to undue risk and deviating from accepted medical practice. The professional reasoning process for similar situations should involve a systematic evaluation of the patient's presentation, a thorough review of the latest evidence and guidelines, consultation with multidisciplinary teams when necessary, and a clear articulation of the rationale for the chosen neuroprotective strategy, always with the patient's best interest as the primary consideration. Question 2. When evaluating a 45-year-old male admitted to the neurocritical care unit following a severe subarachnoid hemorrhage complicated by vasospasm and subsequent ischemic stroke, what is the most appropriate approach to assess his potential for neuroplasticity-driven recovery and guide subsequent management decisions? Option A. Focus solely on the patient's motor deficits as observed during the initial physical examination, assuming that recovery is primarily dependent on the regeneration of damaged neurons. Option B. Conduct serial neurological examinations. Utilize quantitative electroencephalography (QEEG) to assess cortical function and obtain serial diffusion-weighted and perfusion MRI to monitor for evolving ischemic changes and potential areas of plasticity. Option C. Initiate aggressive, high-dose barbiturate coma therapy immediately to suppress neuronal activity and prevent further injury, regardless of specific electrophysiological findings. Option D. Rely primarily on the initial Glasgow Coma Scale, GCS, score, and the extent of the initial hemorrhage on CT angiography to determine the likelihood of recovery. The correct answer is B. Conduct serial neurological examinations. Utilize quantitative electroencephalography, QEEG, to assess cortical function and obtain serial diffusion-weighted and perfusion MRI to monitor for evolving ischemic changes and potential areas of plasticity. Explanation. Scenario analysis. This scenario presents a common yet complex challenge in neurocritical care, predicting and optimizing recovery in a patient with a severe traumatic brain injury, TBI. The difficulty lies in the inherent variability of neuroplasticity, the multifactorial nature of recovery, and the ethical imperative to provide accurate prognostication while maintaining hope and respecting patient autonomy. Clinicians must balance scientific understanding with the individual patient's unique biological response and the family's expectations, all within the framework of established medical standards and ethical guidelines. Correct approach analysis. The correct approach emphasizes a comprehensive, multimodal assessment that integrates objective neurological findings, advanced neuroimaging, and consideration of the patient's underlying physiological state. This aligns with the American Board of Psychiatry and Neurology's APN emphasis on evidence-based practice and a holistic understanding of neurological recovery. Specifically, focusing on serial neurological examination, quantitative measures of brain function, e.g., EEG evoked potentials and structural imaging, e.g., MRI for lesion characterization and potential for neurogenesis or diaskesis resolution, provides the most robust data for prognostication. This approach respects the dynamic nature of neuroplasticity, acknowledging that recovery can occur over extended periods and through various mechanisms, including synaptic plasticity, neurogenesis, and functional reorganization. It also supports shared decision-making by providing a data-driven foundation for discussions with the family about prognosis and treatment goals, adhering to ethical principles of beneficence and non-maleficence. Incorrect approaches analysis. One incorrect approach might focus solely on early, gross neurological deficits without considering the potential for recovery mediated by neuroplastic mechanisms. This could lead to premature withdrawal of care or overly pessimistic prognostication, failing to acknowledge that significant functional gains can be made even after severe initial injury. This approach risks violating the principle of beneficence by not pursuing all reasonable avenues for recovery and potentially misinterpreting the patient's trajectory. Another incorrect approach might rely heavily on a single, static imaging finding without serial reassessment or correlation with functional data. Neuroplasticity is a dynamic process, and a single snapshot may not capture the evolving potential for recovery. This approach could lead to an inaccurate prognosis and suboptimal treatment planning, potentially failing to identify opportunities for targeted rehabilitation. Ethically, it could be seen as a failure to exercise due diligence in patient assessment. A third incorrect approach might prioritize aggressive, unproven interventions without a clear rationale based on neuroplasticity principles or established guidelines. While the desire to help is strong, interventions should be guided by evidence and tailored to the specific injury and recovery potential. This approach could lead to patient harm, resource misallocation, and ethical concerns regarding experimental treatments without proper informed consent or oversight, potentially violating principles of non-maleficence and responsible resource stewardship. Professional reasoning. Professionals should approach such cases by first establishing a clear understanding of the patient's baseline neurological status and the nature of the injury. This is followed by serial, objective assessments of neurological function, incorporating both clinical examination and relevant neurophysiological and neuroimaging data. The interpretation of these findings should be contextualized within the known principles of neuroplasticity and recovery mechanisms. Discussions with the family should be transparent, evidence-based, and empathetic, focusing on realistic expectations and shared goals of care. Regular multidisciplinary team meetings are crucial for synthesizing information and refining the treatment and recovery plan. This systematic, data-driven, and ethically grounded approach ensures that patient care is optimized and aligned with professional standards. Question 3. Benchmark analysis indicates that the definition and scope of neurocritical care are crucial for appropriate patient management and subspecialty training. Considering the American Board of Psychiatry and Neurology (APN) standards for neurocritical care subspecialty certification, which of the following best defines the scope of neurocritical care? Option A. Management of patients with acute neurological conditions that directly affect the brain parenchyma, excluding conditions affecting the spinal cord or peripheral nervous system. Option B. The management of acute neurological insults and their secondary effects, including conditions such as traumatic brain injury, stroke, neurological infections, seizures, and neuromuscular respiratory failure, requiring specialized neurological critical care expertise. Option C. The management of critically ill patients requiring mechanical ventilation due to a primary neurological condition, with no consideration for other neurological critical care interventions. Option D. The management of all critically ill patients who have any neurological comorbidity, irrespective of whether the primary critical illness is neurological in nature. The correct answer is B. The management of acute neurological insults and their secondary effects, including conditions such as traumatic brain injury, stroke, neurological infections, seizures, and neuromuscular respiratory failure, requiring specialized neurological critical care expertise. Explanation: this scenario is professionally challenging due to the inherent ambiguity in defining the precise boundaries of neurocritical care, especially when considering patients with complex neurological conditions that may not fit neatly into traditional intensive care unit (ICU) categories. The need to accurately assess and manage these patients requires a deep understanding of the subspecialty scope, which is governed by the American Board of Psychiatry and Neurology (APN) standards for its subspecialty certification in neurocritical care. The core challenge lies in distinguishing between general critical care and specialized neurocritical care, ensuring that patients receive the most appropriate and expert level of management. The correct approach represents best professional practice because it aligns directly with the APN established framework for neurocritical care. This framework emphasizes the management of acute neurological insults and their secondary effects, encompassing a broad range of conditions from traumatic brain injury and stroke to neurological infections and neuromuscular emergencies. Adhering to this definition ensures that patients are managed by physicians with the specific expertise required to optimize outcomes in this complex patient population, thereby fulfilling the APN mandate for specialized physician training and competence. This approach prioritizes patient safety and quality of care by ensuring that the scope of practice is clearly understood and applied. An incorrect approach that narrowly defines neurocritical care solely to conditions directly affecting the brain parenchyma, excluding conditions like spinal cord injury or neuromuscular respiratory failure, fails to acknowledge the interconnectedness of the nervous system and its impact on critical illness. This would represent a failure to adhere to the comprehensive scope of neurocritical care as understood within the APN purview, potentially leading to suboptimal patient management and a deviation from established subspecialty standards. Another incorrect approach that includes all critically ill patients with any neurological comorbidity, regardless of the primary critical illness, would overextend the definition of neurocritical care beyond its specialized focus. While neurocritical care physicians may consult on such patients, their core expertise is in managing primary neurological emergencies. This broad interpretation would dilute the subspecialty's focus and potentially misallocate resources and expertise, failing to meet the specific requirements for APN certification in neurocritical care. Finally, an approach that limits neurocritical care to only patients requiring mechanical ventilation for neurological reasons would be too restrictive. Neurocritical care encompasses a much wider array of interventions and monitoring, including management of intracranial pressure, seizure management, hemodynamic optimization in the context of neurological injury, and management of neuroinflammatory conditions, many of which do not inherently require mechanical ventilation. This narrow view would fail to capture the full spectrum of conditions and interventions that define the neurocritical care subspecialty according to APN guidelines. The professional decision-making process for similar situations should involve a thorough review of the APN official documentation defining the scope of neurocritical care. When faced with diagnostic or management dilemmas, clinicians should consider whether the patient's primary pathology or the critical illness's management requires specialized neurological expertise beyond general critical care. Consulting relevant subspecialty guidelines, and, if necessary, seeking clarification from the APBIN or established neurocritical care societies, can help ensure adherence to the defined scope of practice and the highest standards of patient care. Question 4. The assessment process reveals a 65-year-old male presenting with sudden onset of severe headache and focal neurological deficits. Initial vital signs show a blood pressure of 210/110 mmHg, heart rate of 88 bpm, and oxygen saturation of 96% on room air. The patient is alert but disoriented. Given the high suspicion for an acute neurological event, what is the most appropriate initial management strategy to optimize patient care within the neurocritical care framework? Option A. Initiate aggressive intravenous fluid resuscitation to improve cerebral perfusion pressure and administer mannitol to reduce intracranial pressure. Option B. Immediately consult neurosurgery for emergent surgical evacuation of a presumed intracerebral hemorrhage without further diagnostic imaging. Option C. Focus on intubation and mechanical ventilation to control ventilation and manage potential airway compromise, deferring blood pressure management and imaging until the patient is stabilized. Option D. Administer intravenous antihypertensive medication to lower blood pressure to a target of 140 mmHg systolic. Obtain emergent non-contrast head CT to confirm diagnosis and assess hematoma characteristics, and initiate continuous neurological monitoring. The correct answer is D. Administer intravenous antihypertensive medication to lower blood pressure to a target of 140 mmHg systolic. Obtain emergent non-contrast head CT to confirm diagnosis and assess hematoma characteristics, and initiate continuous neurological monitoring. Explanation. Scenario analysis. This scenario presents a professionally challenging situation due to the rapid deterioration of a patient with intracerebral hemorrhage (IC). The challenge lies in balancing immediate life-saving interventions with the need for precise diagnostic and therapeutic decision-making under time pressure, while adhering to established neurocritical care protocols and guidelines. The potential for significant neurological deficit or death necessitates a systematic and evidence-based approach. Correct approach analysis. The correct approach, which involves immediate neurological assessment, rapid initiation of blood pressure management according to established guidelines, e.g., sprint or interact trials, and prompt neuroimaging to confirm ICH and guide further management, represents best professional practice. This aligns with the American Board of Psychiatry and Neurology, APBIN, standards for neurocritical care, which emphasize evidence-based interventions and adherence to current best practices for managing acute neurological emergencies. Prompt imaging is crucial for identifying the size, location, and potential cause of the hemorrhage, which directly informs treatment decisions, including surgical intervention if indicated. Blood pressure management is a cornerstone of ICH treatment to prevent hematoma expansion and secondary injury. Incorrect approach is analysis, an approach that delays neuroimaging while focusing solely on supportive care without specific ICH management protocols, fails to adhere to established neurocritical care guidelines. This delay can lead to irreversible neurological damage due to unmanaged hypertension or failure to identify surgical candidates. Ethically, this constitutes a failure to provide timely and appropriate care. An approach that prioritizes aggressive surgical evacuation of the hematoma without confirming the diagnosis with neuroimaging or assessing the patient's hemodynamic stability and neurological status is premature and potentially harmful. This could lead to unnecessary surgical risks and complications without clear benefit, violating the principle of do no harm and failing to follow a systematic diagnostic and therapeutic pathway. An approach that focuses on managing intracranial pressure, IC, without first addressing the primary insult, IC, and controlling blood pressure is misdirected. While ICP management is important in some neurological conditions, in acute ICH, controlling the hemorrhage and blood pressure are the immediate priorities. This approach neglects the root cause and may delay critical interventions, representing a failure to apply appropriate neurocritical care principles. Professional reasoning. Professionals should approach such a scenario by first activating the neurocritical care team and initiating a rapid, systematic assessment. This includes a focused neurological exam, vital sign monitoring, and immediate consideration for neuroimaging. Treatment decisions should be guided by evidence-based protocols for ICH management, including blood pressure targets and indications for surgical intervention. Continuous reassessment and multidisciplinary collaboration are essential for optimizing patient outcomes. Question 5. The monitoring system demonstrates a transient, sharp increase in intracranial pressure from 15 mmHg to 35 mmHg over 30 seconds, followed by a rapid return to baseline within 2 minutes. Simultaneously, cerebral perfusion pressure has remained stable at 70 mmHg, and the patient's Glasgow Coma Scale score is unchanged at 8. Continuous electroencephalography shows no epileptiform activity. Which of the following is the most appropriate immediate management strategy? Option A. Administer a bolus of hyperosmolar therapy and initiate a continuous infusion of an osmotic diuretic. Option B. Initiate a bolus of intravenous mannitol and consider hyperventilation to reduce cerebral blood volume. Option C. Reassess the patient clinically and review the monitoring equipment for potential artifact or malfunction. Option D. Increase sedation and paralysis to minimize metabolic demand and potential for increased intracranial pressure. The correct answer is A. Administer a bolus of hyperosmolar therapy and initiate a continuous infusion of an osmotic diuretic. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in neurocritical care, interpreting complex, multimodal physiological data to guide immediate therapeutic interventions. The difficulty lies in distinguishing between artifact, benign physiological fluctuations, and true pathological changes that necessitate urgent action, all while adhering to established best practices and regulatory guidelines for patient care and data integrity. The potential for misinterpretation carries significant risks, including delayed treatment, unnecessary interventions, and patient harm. Correct approach analysis. The correct approach involves a systematic, integrated interpretation of all available monitoring data, correlating findings with the patient's clinical presentation and known pathophysiology. This aligns with the American Board of Psychiatry and Neurology (APN) standards for neurocritical care, which emphasize comprehensive patient assessment and evidence-based management. Specifically, the APN expects practitioners to demonstrate proficiency in utilizing and interpreting advanced neuromonitoring techniques, such as continuous EEG, invasive intracranial pressure monitoring, and multimodal neuromonitoring, to optimize patient outcomes. This approach prioritizes patient safety and adherence to established clinical pathways for managing neurological emergencies. Incorrect approach is analysis. An approach that solely relies on a single parameter without considering the broader clinical context or other monitoring modalities represents a failure to adhere to comprehensive neurocritical care principles. This could lead to misdiagnosis and inappropriate treatment, potentially violating the APN expectations for skilled interpretation of complex data. For instance, reacting solely to a transient rise in intracranial pressure without considering cerebral perfusion pressure or the patient's neurological exam could lead to unnecessary interventions. Another incorrect approach would be to dismiss concerning trends as artifact without a thorough investigation. The APN expects practitioners to be adept at identifying and troubleshooting monitoring equipment to ensure data accuracy. Failure to do so could result in overlooking critical neurological events, which is a direct contravention of the duty to provide vigilant and accurate patient care. Finally, an approach that delays intervention based on subjective interpretation or personal bias, rather than objective data and established protocols, is professionally unacceptable. Neurocritical care demands prompt, evidence-based decision-making, and any deviation from this standard, particularly when patient safety is at stake, would be considered a failure to meet professional obligations as outlined by the APN. Professional reasoning. Professionals should approach such situations by first establishing a baseline of normal physiological parameters for the individual patient. They must then continuously monitor for deviations, correlating these with clinical signs and symptoms. A structured approach involving a review of all available data streams, e.g., IQ, CPP, EEG, vital signs, neurological exam, is crucial. If a concerning trend emerges, the practitioner must systematically evaluate potential causes, including artifact, physiological changes, or pathological events, before initiating or modifying treatment. This iterative process of monitoring, assessment, and intervention, guided by evidence and established protocols, is the cornerstone of effective neurocritical care. Question 6. Risk assessment procedures indicate a patient presenting with sudden onset of focal neurological deficits, consistent with an acute ischemic stroke, has arrived at the neurocritical care unit. The computed tomography angiography confirms a large vessel occlusion in the middle cerebral artery. However, the neurocritical care unit is currently at maximum capacity with other critically ill patients. There is a perceived shortage of available nursing staff to manage an additional complex patient requiring intensive monitoring and intervention. Which of the following approaches best reflects the appropriate implementation strategy in this time-sensitive scenario? Option A. Postpone consideration of reperfusion therapies until a dedicated bed becomes available in the neurocritical care unit, prioritizing the management of existing patients to ensure their stability. Option B. Proceed directly to mechanical thrombectomy without further imaging confirmation, assuming the initial CT angiography is sufficient to guide the intervention. Option C. Focus on supportive care and medical management of the stroke symptoms, deferring any consideration of reperfusion therapies until the patient's neurological status stabilizes or unit capacity improves. Option D. Initiate the process for mechanical thrombectomy immediately, activating the stroke team and coordinating with the interventional neuroradiology suite, while simultaneously initiating a rapid bed management and staffing reassessment to facilitate patient transfer and care. The correct answer is D. Initiate the process for mechanical thrombectomy immediately, activating the stroke team and coordinating with the interventional neuroradiology suite, while simultaneously initiating a rapid bed management and staffing reassessment to facilitate patient transfer and care. Explanation. This scenario presents a common yet critical implementation challenge in neurocritical care, balancing the rapid administration of evidence-based treatments for acute ischemic stroke with the practical limitations of a busy neurocritical care unit. The professional challenge lies in the time-sensitive nature of stroke interventions, where delays can lead to irreversible neurological damage and poorer patient outcomes. The need for swift decision-making, effective interdisciplinary communication, and efficient resource allocation is paramount. Adherence to established guidelines, such as those from the American Heart Association/American Stroke Association, AHA/ASAD, is not merely a recommendation but a standard of care, implicitly expected by regulatory bodies overseeing quality in healthcare. The correct approach represents best professional practice because it prioritizes patient safety and optimal outcomes by adhering to established protocols for acute ischemic stroke management. This involves a systematic, evidence-based process that ensures timely assessment, appropriate diagnostic imaging, and prompt initiation of reperfusion therapies, thrombolysis and or mechanical thrombectomy, when indicated. This aligns with the core principles of neurocritical care, emphasizing rapid intervention to salvage brain tissue. Regulatory frameworks, while not explicitly dictating every step of a clinical decision, establish expectations for quality of care, patient safety, and adherence to recognized standards, which these guidelines embody. An incorrect approach that involves delaying reperfusion therapy due to concerns about bed availability or staffing levels represents a significant regulatory and ethical failure. Such a delay directly contravenes the time-critical nature of acute ischemic stroke treatment and can lead to preventable morbidity and mortality. This failure to act in accordance with established best practices could be viewed as a breach of the duty of care owed to the patient. Furthermore, it may violate quality metrics and accreditation standards that healthcare facilities are expected to meet, potentially leading to scrutiny from regulatory bodies. Another incorrect approach, such as proceeding with mechanical thrombectomy without adequate imaging confirmation of large vessel occlusion, poses a direct risk to the patient. This bypasses crucial diagnostic steps that inform treatment decisions, potentially leading to unnecessary procedures or failure to identify the most appropriate intervention. This demonstrates a lack of adherence to established diagnostic and treatment pathways, which are foundational to safe and effective patient care. Finally, an approach that focuses solely on managing complications without actively pursuing reperfusion therapy in a patient with confirmed acute ischemic stroke and appropriate indications would be a critical failure. This represents a passive stance in a situation demanding aggressive, time-sensitive intervention, potentially leading to worse functional outcomes for the patient. It signifies a departure from the proactive, evidence-based management expected in neurocritical care. The professional decision-making process for similar situations should involve a rapid, systematic assessment of the patient's neurological status and eligibility for reperfusion therapies. This requires clear communication protocols within the stroke team, including neurologists, neurointerventionalists, emergency physicians, and nursing staff. A pre-established workflow that accounts for potential resource constraints, such as bed availability, and has contingency plans is crucial. The decision to initiate or withhold time-sensitive therapies must always be guided by established clinical guidelines and the individual patient's clinical presentation and imaging findings, prioritizing the potential benefit of intervention over logistical challenges. Question 7. The monitoring system demonstrates a sudden decline in intracranial pressure and a corresponding increase in cerebral perfusion pressure in a patient with severe traumatic brain injury who is currently managed in a general intensive care unit. Given the patient's critical neurological status and the limitations of the current unit in providing advanced neurocritical care interventions, what is the most appropriate next step for the neurocritical care physician to ensure optimal patient management within the U.S. healthcare system? Option A. Recommend transfer to a community hospital with general intensive care capabilities, but lacking specialized neurocritical care expertise, citing potential logistical ease. Option B. Advise the patient's family that the current unit is adequately equipped and that transfer is unnecessary. Focusing on supportive care measures. Option C. Initiate a transfer to a dedicated neurocritical care unit at a tertiary care center equipped to manage complex neurological emergencies. Option D. Continue management in the current unit, closely observing for further changes, and consider pharmacological adjustments based on the current limited monitoring capabilities. The correct answer is C. Initiate a transfer to a dedicated neurocritical care unit at a tertiary care center equipped to manage complex neurological emergencies. Explanation. Scenario analysis. This scenario presents a professional challenge because it requires the neurocritical care physician to balance immediate patient needs with the broader systemic implications of resource allocation and care coordination. The physician must navigate the complexities of interfacility transfers, ensuring continuity of care while adhering to established protocols and ethical considerations. The urgency of the patient's condition necessitates swift action, but this must be tempered by a thorough understanding of the regulatory framework governing such transfers and the role of neurocritical care within the larger healthcare ecosystem. Correct approach analysis. The correct approach emphasizes the physician's responsibility to advocate for the patient's optimal care by facilitating a transfer to a facility with specialized neurocritical care resources. This aligns with the core principles of patient-centered care and the established role of neurocritical care as a specialized service within the healthcare system. Regulatory frameworks, such as those governing patient transfer and access to specialized care, implicitly support such actions when they are medically indicated and in the patient's best interest. This approach demonstrates an understanding of the tiered nature of healthcare services and the importance of directing critically ill neurological patients to centers equipped to manage their complex needs, thereby optimizing outcomes and adhering to best practices in neurocritical care delivery. Incorrect approaches analysis. One incorrect approach involves delaying the transfer due to concerns about bed availability at the receiving facility without first exhausting all reasonable avenues for transfer. This failure to act decisively in the patient's best interest, when specialized care is clearly indicated, could be seen as a dereliction of duty and potentially violate guidelines related to timely access to appropriate medical care. Another incorrect approach is to proceed with the transfer without ensuring adequate communication and documentation between the sending and receiving teams. This lack of coordinated care can lead to gaps in treatment, patient harm, and potential violations of healthcare regulations concerning patient handoffs and continuity of care. It undermines the collaborative nature of neurocritical care and the healthcare system's responsibility to ensure seamless transitions. A third incorrect approach is to prioritize the convenience of the sending facility over the patient's medical needs by suggesting a less specialized facility for initial management. This decision-making process fails to recognize the unique and time-sensitive requirements of neurocritical care patients and deviates from the established role of specialized neurocritical care units in managing these complex cases. Such a decision could be viewed as a failure to provide appropriate medical care as dictated by the patient's condition and the availability of specialized resources. Professional reasoning. Professionals should approach such situations by first assessing the patient's immediate medical needs and the availability of specialized neurocritical care resources. This involves a clear understanding of the patient's neurological condition and the specific interventions required. Next, they must consult relevant institutional policies and regulatory guidelines pertaining to interfacility transfers and the provision of specialized care. The decision-making process should prioritize patient well-being, ensuring that the transfer is medically justified and that all necessary steps are taken to facilitate a safe and effective transition of care. This includes proactive communication with the receiving facility and ensuring that the patient's medical information is comprehensively transferred. Question 8. System analysis indicates that a neurocritical care unit is experiencing challenges in coordinating care for a patient with a complex subarachnoid hemorrhage and evolving vasospasm, leading to concerns about fragmented communication and potential delays in therapeutic interventions. The attending neurointensivist has observed that while individual team members are highly skilled, the overall team's ability to synthesize information and make timely, unified decisions appears suboptimal. The unit is seeking to implement a more effective interdisciplinary team approach to address these implementation challenges. Which of the following approaches would best foster a cohesive and effective interdisciplinary team in this neurocritical care setting? Option A. Conduct weekly, unstructured team meetings where team members can share general updates without a specific focus on individual patient care plans. Option B. Encourage informal, ad hoc communication between individual team members as needed, trusting their professional judgment to coordinate care independently. Option C. Establish a system where rounds are primarily led by the most senior physician present, with other disciplines contributing only when directly asked specific questions. Option D. Implement daily, structured interdisciplinary rounds led by a designated team leader, with a clear agenda covering neurological status, hemodynamics, respiratory management, and a collaborative problem-solving approach to care planning. The correct answer is D. Implement daily, structured interdisciplinary rounds led by a designated team leader, with a clear agenda covering neurological status, hemodynamics, respiratory management, and a collaborative problem-solving approach to care planning. Explanation. Scenario analysis. This scenario presents a common challenge in neurocritical care, ensuring seamless and effective communication and collaboration among a diverse interdisciplinary team when managing a critically ill patient with a complex neurological condition. The inherent complexity of neurocritical care, involving rapid changes in patient status, the need for specialized interventions, and the involvement of multiple disciplines, neurology, critical care, nursing, respiratory therapy, pharmacy, etc., makes effective teamwork paramount. The challenge lies in overcoming potential silos, differing professional perspectives, and time constraints to achieve optimal patient outcomes. Correct approach analysis. The correct approach emphasizes structured, regular interdisciplinary rounds with a designated leader and a clear agenda focused on shared decision-making and problem-solving. This aligns with best practices in patient safety and quality improvement, as supported by guidelines from professional organizations like the American Academy of Neurology and the Society of Critical Care Medicine, which advocate for collaborative care models. A designated leader ensures efficient communication, facilitates discussion, and promotes accountability. A structured agenda ensures all critical aspects of the patient's care are addressed, including neurological status, hemodynamic stability, respiratory support, and potential complications. Shared decision-making empowers all team members to contribute their expertise, leading to more comprehensive and patient-centered care plans. This approach directly addresses the potential for miscommunication and fragmented care, thereby enhancing patient safety and improving clinical outcomes, which are core tenets of neurocritical care practice. Incorrect approaches analysis. One incorrect approach involves relying solely on informal, ad hoc communication between individual team members. This fails to establish a consistent, comprehensive understanding of the patient's status and care plan among the entire team. It increases the risk of miscommunication, missed critical information, and duplicated or conflicting interventions, violating principles of patient safety and potentially leading to adverse events. This fragmented communication model is not supported by any established regulatory or ethical framework, for team-based care in critical settings. Another incorrect approach is to have rounds led by a single discipline without active, structured input from all other essential team members. This can lead to a narrow focus on one aspect of care, potentially overlooking critical issues from other disciplines. It undermines the collaborative spirit essential for neurocritical care and can result in suboptimal treatment plans. Ethically, it fails to leverage the full expertise available to the patient, and from a regulatory perspective, it deviates from the expected standard of care for interdisciplinary team collaboration in critical care. A third incorrect approach is to conduct rounds without a clear agenda or defined objectives, allowing discussions to become unfocused and unproductive. This wastes valuable time, leads to frustration among team members, and increases the likelihood that critical issues will be overlooked. Such an unstructured approach is inefficient and can compromise patient care by failing to systematically address all necessary aspects of management, thus not meeting the standards of professional practice expected in a high-acuity environment. Professional reasoning. Professionals should approach interdisciplinary team challenges by prioritizing structured communication and shared decision-making. This involves establishing clear protocols for team interactions, such as regular, well-led rounds with defined roles and objectives. When faced with a complex patient, the decision-making process should involve actively soliciting input from all relevant disciplines, synthesizing this information to develop a unified care plan, and ensuring clear communication of that plan to all team members and the patient's family. This systematic approach, grounded in patient safety principles and collaborative care models, is essential for navigating the complexities of neurocritical care and achieving optimal patient outcomes. Question 9. The efficiency study reveals that in cases of refractory status epilepticus, RSE, where initial benzodiazepine and a second-line antiepileptic drug have failed, a significant delay in initiating further aggressive management is observed. A 55-year-old male with a history of autoimmune encephalitis presents to the neurocritical care unit with generalized tonic-clonic seizures that have been ongoing for 45 minutes despite intravenous lorazepam and fosphenytoin. Continuous EEG confirms ongoing seizure activity. What is the most appropriate next step in management? Option A. Initiate continuous infusion of an anesthetic agent such as midazolam or propofol, targeting burst suppression on EEG. Option B. Increase the dose of fosphenytoin and continue to monitor for seizure cessation. Option C. Administer a third-line oral antiepileptic drug and await its absorption and efficacy. Option D. Obtain an MRI of the brain to further investigate the underlying autoimmune process before escalating treatment. The correct answer is A. Initiate continuous infusion of an anesthetic agent such as midazolam or propofol, targeting burst suppression on EEG. Explanation. This scenario presents a common yet critical challenge in neurocritical care, managing refractory status epilepticus, RSE, in a patient with a known history of autoimmune encephalitis. The professional challenge lies in the urgency of the situation, the potential for irreversible neurological damage, and the need to balance aggressive treatment with the avoidance of iatrogenic complications. The patient's underlying condition adds complexity, as it may influence treatment response and necessitate a tailored approach. Careful judgment is required to select the most appropriate next step in management, considering both established guidelines and individual patient factors. The correct approach represents best professional practice by adhering to established neurocritical care guidelines for RSE management, specifically the tiered approach to pharmacologic intervention. This involves escalating therapy systematically when initial treatments fail. In this case, after failure of benzodiazepines and a second-line antiepileptic drug, EED, the next logical step is the initiation of continuous infusions of anesthetic agents, such as midazolam, propofol, or barbiturates, to induce a burst suppression pattern on electroencephalography, EEG. This strategy is supported by evidence and is considered the standard of care for RSE, aiming to rapidly terminate seizure activity and prevent neuronal injury. This aligns with the American Board of Psychiatry and Neurology's emphasis on evidence-based practice and adherence to establish protocols for critical neurological conditions. An incorrect approach would be to delay further escalation of therapy, such as waiting for further diagnostic workup before initiating anesthetic agents. This represents a regulatory and ethical failure because it deviates from the established time-sensitive management of RSE. Prolonged seizures cause excitotoxicity, neuronal apoptosis, and potential long-term cognitive deficits. Delaying effective treatment constitutes a failure to provide timely and appropriate care, potentially violating the ethical principle of beneficence and the professional obligation to act in the patient's best interest. Another incorrect approach would be to solely focus on treating the underlying autoimmune encephalitis without concurrently addressing the RSE with appropriate antiepileptic measures. While treating the underlying cause is crucial, it does not negate the immediate need to control the ongoing seizure activity, which itself can exacerbate the inflammatory process and cause further harm. This would be a failure to recognize the dual nature of the problem and prioritize immediate life-saving interventions. A professional decision-making process for similar situations should involve a rapid assessment of the patient's status, immediate implementation of established RSE protocols, continuous EEG monitoring to confirm seizure cessation and guide therapy, and a multidisciplinary approach involving neurology, critical care, and pharmacy. Clinicians must be proficient in recognizing RSE, understanding the pharmacologic options and their associated risks, and making timely decisions regarding escalation of care. This involves a systematic evaluation of treatment efficacy and patient response, with a willingness to adapt the treatment plan based on evolving clinical and electrophysiological data, always prioritizing the patient's neurological well-being. Question 10. Risk assessment procedures indicate a 55-year-old male admitted with severe traumatic brain injury and an initial Glasgow Coma Scale score of 6. Intracranial pressure monitoring reveals a sustained ICP of 25 mmHg with calculated cerebral perfusion pressure, CPP, averaging 50 mmHg. Initial CT scan shows diffuse cerebral edema. The Neurocritical care team is considering interventions to improve cerebral blood flow and metabolism. Which of the following represents the most appropriate initial management strategy? Option A. Administer a bolus of mannitol to reduce ICP and improve cerebral blood flow without immediate adjustments to MAP. Option B. Increase sedation and paralysis to reduce metabolic demand and cerebral oxygen consumption, accepting the current CPP. Option C. Initiate hyperventilation to a POS CO2 of 25 mmHg to reduce cerebral blood volume and ICP. Option D. Initiate a continuous infusion of norepinephrine to increase mean arterial pressure, MAP, and subsequently CPP, while closely monitoring ICP and neurological status for response. The correct answer is D. Initiate a continuous infusion of norepinephrine to increase mean arterial pressure, MAP, and subsequently CPP, while closely monitoring ICP and neurological status for response. Explanation. Scenario analysis. This scenario presents a common yet complex challenge in neurocritical care, managing a patient with a traumatic brain injury, TBI, and evidence of impaired cerebral blood flow and metabolism. The core difficulty lies in balancing the need to maintain adequate cerebral perfusion pressure, CPP, with the risks of exacerbating intracranial hypertension, IC, and the potential for secondary brain injury. The physician must integrate clinical assessment, neuromonitoring data, and physiological principles to guide therapeutic interventions, all while adhering to established guidelines and ethical principles of patient care. The absence of definitive, universally agreed-upon thresholds for all interventions adds to the complexity, requiring nuanced clinical judgment. Correct approach analysis. The correct approach involves a systematic, multimodal strategy that prioritizes the restoration and maintenance of adequate cerebral blood flow and metabolism, while mitigating secondary insults. This aligns with the American Board of Psychiatry and Neurology Subspecialty in neurocritical care's emphasis on evidence-based practice and patient safety. Specifically, optimizing CPP through judicious fluid management and vasopressors, while simultaneously addressing potential causes of increased intracranial pressure such as edema or venous congestion, represents best professional practice. This approach is supported by guidelines from neurocritical care societies that advocate for individualized management based on neuromonitoring and clinical status, aiming to prevent ischemic and excitotoxic injury. The focus on preventing secondary insults is paramount in neurocritical care, as these are often modifiable and directly impact neurological outcomes. Incorrect approaches analysis. One incorrect approach would be to solely focus on maintaining a high mean arterial pressure, MAP, without considering the intracranial pressure I or cerebral autoregulation status. This could lead to excessive CPP, potentially causing hyperemia and exacerbating cerebral edema, which is a failure to adhere to the principle of avoiding iatrogenic harm and could violate guidelines that emphasize individualized CPP targets based on autoregulatory capacity. Another incorrect approach would be to aggressively manage ICP with hyperosmolar therapy without first ensuring adequate cerebral perfusion. This could paradoxically worsen ischemia by reducing circulating blood volume and further impairing blood flow to already compromised brain tissue, representing a failure to prioritize the fundamental requirement of oxygen and substrate delivery to the brain. A third incorrect approach would be to delay or withhold interventions aimed at optimizing cerebral blood flow and metabolism due to uncertainty or a desire to avoid potential side effects, thereby allowing secondary insults to progress. This inaction constitutes a failure to provide timely and appropriate care, potentially leading to irreversible neurological damage and violating the ethical obligation to act in the patient's best interest. Professional reasoning. In managing patients with TBI and compromised cerebral blood flow, professionals should employ a structured decision-making process. This involves 1. Thoroughly assessing the patient's neurological status and hemodynamic parameters. 2. Interpreting neuromonitoring data e.g., ICE, CPP, jugular venous oxygen saturation, microdialysis, in the context of the patient's overall physiology. 3. Identifying potential reversible causes of impaired cerebral blood flow and metabolism. 4. Formulating a treatment plan that is individualized, evidence-based, and aims to optimize CPP while minimizing ICP and preventing secondary insults. 5. Continuously reassessing the patient's response to interventions and adjusting the treatment strategy accordingly. This iterative process ensures that care remains dynamic and responsive to the patient's evolving condition, adhering to the highest standards of neurocritical care practice. Question 11. Market research demonstrates that continuous electroencephalography, CEEG, is increasingly utilized in neurocritical care units. A neurocritical care physician is reviewing a CEEG recording for a patient with a recent subarachnoid hemorrhage who has developed new-onset focal motor seizures. The physician notes several brief, rhythmic sharp-wave discharges in the left temporal region that are not clearly associated with any overt motor activity at that moment. Which of the following represents the most appropriate next step in managing this patient's CEEG interpretation and subsequent care? Option A. Immediately initiate a loading dose of a broad-spectrum antiepileptic drug and continue CEEG monitoring to assess for resolution of the sharp wave discharges. Option B. Increase the frequency of neurological examinations and titrate sedating medications to suppress any potential subclinical epileptiform activity without further EEG review. Option C. Correlate the observed sharp wave discharges with the patient's overall clinical status, neurological examination, and other physiological monitoring data, and consider consultation with a neurophysiologist if the findings are equivocal or concerning for subclinical seizure activity. Option D. Document the sharp wave discharges as likely artifact given the lack of overt clinical correlation, and discontinue CEEG monitoring to conserve resources. The correct answer is A. Immediately initiate a loading dose of a broad-spectrum antiepileptic drug and continue CEEG monitoring to assess for resolution of the sharp wave discharges. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the neurocritical care physician to interpret complex EEG data in a dynamic, high-stakes environment where patient status can change rapidly. The physician must balance the need for timely intervention with the potential for overinterpretation or misinterpretation of subtle EEG findings, which can lead to unnecessary or even harmful treatments. The pressure to make critical decisions based on incomplete or evolving information is a hallmark of neurocritical care. Correct approach analysis. The correct approach, which involves a systematic review of the entire EEG recording, correlation with the patient's clinical status and other monitoring data, and consultation with a neurophysiologist when indicated, represents best professional practice. This aligns with the American Board of Psychiatry and Neurology's emphasis on evidence-based practice and the highest standards of patient care. The APPEN Subspecialty in Neurocritical Care expects practitioners to integrate all available data, including continuous EEG, to form a comprehensive understanding of the patient's neurological condition. This approach minimizes the risk of misdiagnosis and ensures that interventions are guided by a thorough assessment, adhering to the principles of patient safety and quality of care. Incorrect approaches analysis. One incorrect approach involves solely relying on automated EEG interpretation software without clinical correlation. This fails to meet professional standards because automated systems can have limitations in detecting subtle patterns or distinguishing artifacts from true epileptiform activity, especially in critically ill patients with fluctuating physiological states. Such an approach risks misinterpreting benign phenomena as pathological or missing critical events, potentially leading to delayed or inappropriate management, which is a failure of due diligence and patient advocacy. Another incorrect approach is to disregard EEG findings that do not immediately correlate with overt clinical changes. This is professionally unacceptable because subclinical seizures or evolving patterns of cerebral dysfunction can precede overt clinical manifestations. Ignoring these findings can lead to a missed opportunity for early intervention, potentially resulting in secondary brain injury or prolonged neurological impairment. This demonstrates a lack of comprehensive neurological assessment and a failure to proactively manage neurological risk. A third incorrect approach is to order frequent, unscheduled EEG studies based on minor, nonspecific clinical fluctuations without a clear hypothesis or change in management plan. This represents inefficient use of resources and can lead to EEG fatigue for the interpreting physician, potentially increasing the risk of overlooking significant findings amidst a deluge of data. It also fails to adhere to the principle of ordering diagnostic tests with a specific clinical question in mind, which is a cornerstone of responsible medical practice. Professional reasoning. When faced with EEG interpretation in the neurocritical care setting, professionals should adopt a structured approach. This begins with understanding the clinical context, the patient's underlying condition, recent events, and current neurological status. Next, a systematic review of the EEG data is performed, looking for specific patterns, abnormalities, and changes over time. Crucially, this EEG data must be integrated with other available monitoring information, such as vital signs, intracranial pressure, and neurological examination findings. If uncertainty exists or complex patterns are observed, consultation with a neurophysiologist is a critical step. This iterative process of data acquisition, interpretation, correlation, and consultation ensures that decisions are informed, evidence-based, and patient-centered, aligning with the rigorous standards expected of APN-certified neurocritical care specialists. Question 12. The assessment process reveals a 72-year-old male admitted with an acute ischemic stroke secondary to atrial fibrillation. He has a history of hypertension, hyperlipidemia, and type 2 diabetes mellitus. Following successful reperfusion therapy and stabilization in the neurocritical care unit, the team is planning for discharge and long-term management. Which of the following strategies best represents the optimal approach to secondary prevention in this patient? Option A. Initiate anticoagulation for atrial fibrillation. Optimize blood pressure control to target 130/80 mmHg. Manage dyslipidemia with statin therapy. Ensure glycemic control with an HbA1c target of 7%, and counsel on lifestyle modifications including diet and exercise. Option B. Recommend a low-intensity statin and a beta blocker with no specific intervention for his atrial fibrillation as the stroke was ischemic. Option C. Focus solely on physical rehabilitation to regain motor function, deferring all secondary prevention measures until the patient is more stable and independent. Option D. Prescribe a high-intensity statin and aspirin, assuming these will adequately address all risk factors for recurrent stroke, regardless of the underlying etiology. Correct answer is A. Initiate anticoagulation for atrial fibrillation. Optimize blood pressure control to target 130/80 mmHg. Manage dyslipidemia with statin therapy. Ensure glycemic control with an HbA1c target of 7%. And counsel on lifestyle modifications including diet and exercise. Explanation. This scenario presents a professionally challenging situation because it requires balancing immediate post-stroke management with long-term secondary prevention, a critical phase for reducing recurrence and improving patient outcomes. The physician must navigate complex clinical data, patient comorbidities, and evidence-based guidelines to formulate an optimal, individualized plan. The challenge lies in the integration of acute care needs with the initiation and adherence to chronic management strategies, often in the context of limited resources and patient or family-related barriers. The correct approach represents best professional practice by prioritizing a comprehensive, evidence-based secondary prevention strategy tailored to the patient's specific stroke etiology and risk factors, as mandated by established neurocritical care guidelines and recommendations from professional organizations such as the American Heart Association/American Stroke Association. This includes aggressive management of modifiable risk factors like hypertension, dyslipidemia, diabetes, and atrial fibrillation, alongside appropriate antiplatelet or anticoagulant therapy and lifestyle modifications. Adherence to these guidelines ensures the highest standard of care, aiming to minimize the risk of recurrent stroke and its associated morbidity and mortality, aligning with the core ethical principles of beneficence and non-maleficence. An incorrect approach that focuses solely on immediate neurological recovery, without a robust secondary prevention plan, fails to meet the standard of care. This represents a regulatory and ethical failure by neglecting a crucial aspect of stroke management that directly impacts long-term patient well-being and survival. Similarly, an approach that implements a generic, non-individualized prevention strategy, disregarding the patient's specific stroke type, comorbidities, or contraindications, is also professionally unacceptable. This can lead to suboptimal outcomes or iatrogenic harm, violating the principle of individualized care and potentially contravening guidelines that emphasize personalized treatment plans. Furthermore, failing to involve the patient and family in shared decision-making regarding the prevention plan, or neglecting to address potential barriers to adherence, constitutes an ethical lapse in patient autonomy and communication. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's clinical presentation, stroke etiology, and all modifiable risk factors. This should be followed by a thorough review of current, evidence-based guidelines for secondary stroke prevention. The physician must then engage in shared decision-making with the patient and their family, explaining the rationale for recommended interventions, potential benefits, risks, and alternatives. A multidisciplinary approach, involving nurses, pharmacists, physical and occupational therapists, and social workers, is often essential to address all aspects of the patient's needs and facilitate adherence to the prevention plan. Ongoing monitoring and adjustment of the treatment plan based on patient response and evolving clinical status are also critical components of best practice. Question 13. Compliance review shows that a 45-year-old male admitted with a T4 complete spinal cord injury following a motor vehicle accident has been managed in the neurocritical care unit for 72 hours. The patient remains hemodynamically unstable with recurrent episodes of autonomic dysreflexia, and his neurological examination has not changed. The multidisciplinary team is debating the optimal next steps in his care. Which of the following approaches best aligns with current neurocritical care, best practices, and regulatory expectations for subspecialty training and practice in the United States? Option A. Focus on optimizing hemodynamic parameters and managing autonomic dysreflexia with prompt identification and removal of noxious stimuli, alongside early consultation with physical and occupational therapy to begin passive range of motion and initiate a comprehensive rehabilitation plan. Option B. Increase the dose of corticosteroids to reduce spinal cord inflammation, assuming this will expedite neurological recovery and continue to monitor vital signs without immediate multidisciplinary rehabilitation team involvement. Option C. Initiate aggressive pharmacological management for autonomic dysreflexia with a combination of alpha blockers and vasodilators, while deferring formal physical and occupational therapy until hemodynamic stability is achieved and autonomic dysreflexia is fully controlled. Option D. Continue current supportive care, including intravenous fluids and vasopressors for blood pressure support, and postpone any discussions about long-term prognosis or rehabilitation until the patient demonstrates significant neurological improvement. Correct answer is C. Initiate aggressive pharmacological management for autonomic dysreflexia with a combination of alpha blockers and vasodilators, while deferring formal physical and occupational therapy until hemodynamic stability is achieved and autonomic dysreflexia is fully controlled. Explanation. This scenario presents a professional challenge due to the inherent complexity of managing spinal cord injuries, (PSI), in a neurocritical care setting, requiring a multidisciplinary approach and adherence to evolving evidence-based guidelines. The challenge lies in balancing immediate life-saving interventions with long-term functional recovery and patient-centered care, all within the strict regulatory and ethical framework governing medical practice in the United States, as overseen by bodies like the Accreditation Council for Graduate Medical Education, (ACME), for fellowship training, and the American Board of Psychiatry and Neurology, (APN), for board certification. The correct approach represents best professional practice because it prioritizes a comprehensive, evidence-based, and multidisciplinary strategy for PSI management. This aligns with ACME requirements for fellowship training, which emphasize the integration of clinical skills, ethical judgment, and patient advocacy. Specifically, it reflects the APN expectation that subspecialists demonstrate mastery of current diagnostic and therapeutic modalities, including the judicious use of pharmacological agents and the timely initiation of rehabilitation services, all while ensuring patient safety and informed consent. This approach is grounded in the principles of beneficence and non-maleficence, ensuring the patient receives optimal care tailored to their specific neurological deficits and overall health status. An incorrect approach that focuses solely on aggressive pharmacological interventions without considering the patient's overall condition or the potential for adverse effects would be professionally unacceptable. This would violate the principle of non-maleficence by potentially causing harm without commensurate benefit. Furthermore, it could be seen as a failure to adhere to evidence-based guidelines, which are implicitly expected under APN certification standards, and could lead to suboptimal outcomes. Another incorrect approach that delays or inadequately coordinates rehabilitation services would be ethically problematic. This neglects the principle of beneficence by failing to maximize the patient's potential for recovery and functional independence. Such a delay could also be viewed as a failure to meet the standards of care expected in neurocritical care, potentially leading to long-term disability and reduced quality of life, which are critical considerations for APN-certified physicians. A third incorrect approach that fails to adequately involve the patient and their family in decision-making, particularly regarding goals of care and treatment options, would be a significant ethical lapse. This violates the principle of patient autonomy and the requirement for informed consent, which are fundamental to U.S. healthcare regulations and ethical medical practice. Effective communication and shared decision-making are crucial for building trust and ensuring that treatment plans align with the patient's values and preferences. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's neurological status, hemodynamic stability, and overall medical condition. This should be followed by a collaborative discussion among the neurocritical care team, including neurologists, neurosurgeons, intensivists, nurses, and rehabilitation specialists. Evidence-based guidelines for PSI management should be consulted, and treatment decisions should be individualized to the patient's specific needs and circumstances. Crucially, open and transparent communication with the patient and their family is paramount, ensuring they are informed about the diagnosis, prognosis, treatment options, and potential risks and benefits, thereby facilitating shared decision-making and respecting their autonomy. Question 14. The monitoring system demonstrates a progressive increase in generalized cortical slowing on electroencephalography, (EEG), in a patient with a history of status epilepticus treated with a benzodiazepine infusion. The patient's vital signs are stable, and there are no new focal neurological deficits on examination. Considering the potential impact of pharmacological agents on neurotransmission, which of the following is the most appropriate initial interpretation and management strategy? Option A. The EEG findings are likely a sign of developing cytotoxic edema, indicating a need for immediate initiation of hyperosmolar therapy to reduce intracranial pressure. Option B. The EEG changes may represent a paradoxical excitatory effect or withdrawal phenomenon related to the benzodiazepine infusion, suggesting a cautious reduction in the benzodiazepine dosage while closely monitoring the EEG and clinical status. Option C. The EEG changes are most likely a manifestation of a metabolic encephalopathy, requiring urgent laboratory investigations to assess electrolyte and glucose levels without altering current pharmacological management. Option D. The EEG changes are most likely indicative of a recurrence of status epilepticus due to a decrease in inhibitory neurotransmission, necessitating an immediate increase in the benzodiazepine infusion rate. Correct answer is D. The EEG changes are most likely indicative of a recurrence of status epilepticus due to a decrease in inhibitory neurotransmission, necessitating an immediate increase in the benzodiazepine infusion rate. Explanation. Scenario analysis. This scenario presents a common challenge in neurocritical care, interpreting complex physiological data in the context of a patient with altered neurotransmission. The difficulty lies in distinguishing between a primary neurological event affecting synaptic function and a secondary complication, such as an electrolyte imbalance or medication side effect, that mimics neurological dysfunction. The physician must integrate real-time monitoring data with clinical presentation and knowledge of neuropharmacology and neurophysiology to make timely and accurate therapeutic decisions, directly impacting patient outcomes and resource utilization. The APBIN Neurocritical Care Subspecialty exam emphasizes the application of scientific knowledge to clinical practice within the established regulatory and ethical frameworks governing patient care in the United States. Correct approach analysis. The correct approach involves a systematic evaluation of the observed electrophysiological changes in conjunction with the patient's clinical status and known pharmacological interventions. Specifically, recognizing that a decrease in inhibitory neurotransmission, e.g., GABAergic, or an increase in excitatory neurotransmission, e.g., glutamatergic, can manifest as increased cortical excitability, as indicated by the EEG findings, is crucial. The physician's responsibility, as guided by U.S. medical practice standards and the ethical principles of beneficence and non-maleficence, is to identify the most likely underlying cause and initiate appropriate management. In this context, considering the potential for medication-induced changes in neurotransmission, such as the withdrawal of a GABAergic agent or the administration of a stimulant, and correlating this with the EEG pattern, represents best professional practice. This aligns with the standards of care for neurocritical care patients, which mandate a thorough and evidence-based approach to diagnosis and treatment. Incorrect approaches analysis. One incorrect approach would be to solely focus on the EEG abnormalities without considering the patient's medication regimen or recent clinical events. This violates the principle of holistic patient assessment, which is a cornerstone of U.S. medical practice. Failing to consider iatrogenic causes of altered neurotransmission, such as medication withdrawal or adverse drug reactions, can lead to misdiagnosis and inappropriate treatment, potentially harming the patient. This also falls short of the physician's duty to provide competent care as expected within the U.S. healthcare system. Another incorrect approach would be to immediately escalate to aggressive, potentially invasive interventions without a clear understanding of the underlying mechanism. For instance, initiating broad-spectrum anticonvulsant therapy without first attempting to identify and reverse a reversible cause of increased cortical excitability would be premature and could lead to unnecessary side effects and complications. This contravenes the ethical principle of proportionality in treatment and the regulatory expectation for evidence-based medical decision-making. A third incorrect approach would be to attribute the EEG changes solely to a primary neurological insult, without considering other systemic factors that can influence neuronal excitability. Electrolyte disturbances, metabolic derangements, or even hypoxia can significantly impact neurotransmission and EEG patterns. Ignoring these possibilities, which are common in critically ill patients, would represent a failure to adhere to comprehensive diagnostic principles expected in U.S. neurocritical care practice. Professional reasoning. Professionals facing such a scenario should employ a structured diagnostic process. First, thoroughly review the patient's current clinical status, including vital signs, neurological examination, and any recent changes. Second, meticulously examine the medication list, paying close attention to agents that affect neurotransmission, and consider recent changes in dosage or administration. Third, correlate the observed EEG findings with the clinical picture and pharmacological context. Fourth, consider and rule out common systemic causes of altered neurological function. Finally, formulate a differential diagnosis and initiate targeted investigations and interventions based on the most probable etiology, always prioritizing patient safety and adherence to established medical standards and ethical guidelines within the United States. Question 15. Cost-benefit analysis shows that while advanced neuromonitoring technologies like NIRS and brain tissue oxygenation monitoring offer potential insights into cerebral hemodynamics and oxygenation, their widespread adoption in neurocritical care units should be guided by a framework that emphasizes evidence-based efficacy and resource optimization. Which of the following approaches best reflects this principle for integrating such technologies? Option A. Deferring the use of NIRS and brain tissue oxygenation monitoring indefinitely due to their initial high acquisition and maintenance costs, without a comprehensive evaluation of their potential to reduce long-term patient morbidity and overall healthcare expenditure. Option B. Prioritizing the adoption and routine use of NIRS and brain tissue oxygenation monitoring based on peer-reviewed literature demonstrating improved patient outcomes, cost-effectiveness, and alignment with established clinical guidelines for specific patient populations. Option C. Relying primarily on the personal experience and anecdotal reports of senior clinicians within the unit to determine the necessity and application of NIRS and brain tissue oxygenation monitoring. Option D. Implementing NIRS and brain tissue oxygenation monitoring broadly across all neurocritical care patients as soon as they become available, assuming their advanced capabilities will inherently improve care. The correct answer is D. Implementing NIRS and brain tissue oxygenation monitoring broadly across all neurocritical care patients as soon as they become available, assuming their advanced capabilities will inherently improve care. Explanation. Scenario analysis. This scenario presents a professional challenge in neurocritical care by requiring the clinician to balance the potential benefits of advanced neuromonitoring technologies against their resource implications and the need for evidence-based application. The challenge lies in moving beyond the mere availability of technology to its judicious and effective integration into patient care, ensuring that its use is justified by improved patient outcomes and aligns with established clinical guidelines and the principles of resource stewardship. Correct approach analysis. The correct approach represents best professional practice because it prioritizes the systematic evaluation of neuromonitoring technologies based on their demonstrated efficacy, safety, and cost-effectiveness within the specific context of neurocritical care. This aligns with the American Board of Psychiatry and Neurology's emphasis on evidence-based medicine and the responsible application of advanced diagnostic and therapeutic tools. Adherence to guidelines from professional organizations, such as the Neurocritical Care Society, which informs AP and subspecialty standards, and a commitment to continuous quality improvement are paramount. This approach ensures that technology adoption is driven by patient benefit and sound clinical judgment, rather than solely by technological novelty or availability, thereby upholding ethical obligations to provide high-quality, efficient care. Incorrect approaches analysis. One incorrect approach involves the uncritical adoption of every new neuromonitoring technology as it becomes available, without rigorous validation of its clinical utility or cost-effectiveness. This represents a failure to adhere to principles of evidence-based practice and responsible resource allocation, potentially leading to unnecessary expenditures and a diversion of resources from proven interventions. Ethically, it can be seen as a deviation from the duty to provide care that is both effective and efficient. Another incorrect approach is to rely solely on anecdotal evidence or the experience of individual clinicians when deciding on the implementation of neuromonitoring technologies. While individual experience is valuable, it does not substitute for robust, peer-reviewed data and systematic evaluation. This approach risks perpetuating the use of technologies that may not be universally beneficial or may have significant limitations, failing to meet the standards of objective clinical decision-making expected in neurocritical care. A third incorrect approach is to dismiss neuromonitoring technologies outright due to perceived high costs, without a thorough assessment of their potential to improve patient outcomes, reduce complications, or shorten hospital stays. This can lead to a missed opportunity to optimize patient care and may result in suboptimal outcomes that are ultimately more costly in terms of patient morbidity and healthcare resource utilization. It represents a failure to engage in a comprehensive cost-benefit analysis that considers the full spectrum of patient and system impacts. Professional reasoning. Professionals should approach the integration of neuromonitoring technologies by first understanding the specific clinical questions the technology aims to answer and the patient populations for whom it is intended. This involves consulting current evidence-based guidelines, engaging in critical appraisal of research literature, and participating in institutional review processes that evaluate new technologies. A framework that includes pilot testing, outcome monitoring, and ongoing re-evaluation of technology use is essential. Decision-making should be a collaborative process involving neurointensivists, neurologists, neurosurgeons, nurses, and hospital administrators, with a shared commitment to patient safety, clinical effectiveness, and fiscal responsibility. Question 16. Assessment of the utility and interpretation of transcranial Doppler, TCD, ultrasound in a neurocritical care unit is being considered for routine use in patients with subarachnoid hemorrhage to monitor for vasospasm. The neurocritical care team is debating the most appropriate implementation strategy to ensure accurate and clinically relevant application of this technology, adhering to the standards expected for subspecialty practice in neurocritical care. Option A. TCD studies will be performed by a neurocritical care fellow, and the interpretation will be reviewed and signed off by a neuroradiologist who has no specific expertise in neurocritical care, or TCD. Option B. TCD studies will be performed by a dedicated radiology technician, and the interpretation will be solely based on the automated software analysis provided by the TCD machine. Option C. TCD studies will be performed by trained neurocritical care nurses, and the raw Doppler data will be reviewed and interpreted by the attending neurocritical care physician responsible for the patient's care, who has access to TCD interpretation guidelines. Option D. TCD studies will be performed by any physician in the neurocritical care unit who has attended a basic TCD workshop, and the interpretation will be documented as performed and interpreted by physician. The correct answer is C. TCD studies will be performed by trained neurocritical care nurses, and the raw Doppler data will be reviewed and interpreted by the attending neurocritical care physician responsible for the patient's care, who has access to TCD interpretation guidelines. Explanation. This scenario presents a common implementation challenge in neurocritical care, integrating a new diagnostic modality, transcranial Doppler, TCD, ultrasound, into routine patient management within the constraints of established protocols and physician expertise. The professional challenge lies in ensuring accurate and timely interpretation of TCD findings to guide clinical decisions, particularly in the absence of readily available subspecialty expertise for every interpretation. This requires not only technical proficiency in performing the ultrasound, but also a deep understanding of TCD hemodynamics and their correlation with neurological status, all while adhering to the American Board of Psychiatry and Neurology (ABPN) standards for subspecialty practice. The correct approach represents best professional practice because it prioritizes patient safety and optimal care by ensuring that TCD interpretations are performed by individuals with demonstrated competence and appropriate training, aligning with the ABPN commitment to high standards in neurocritical care. This involves a structured process of credentialing and ongoing quality assurance, ensuring that the interpretation is not merely a technical act, but a clinically meaningful assessment integrated into the patient's overall management plan. This aligns with the ethical imperative to provide care based on validated knowledge and skills. Incorrect approaches fail to meet professional standards due to several regulatory and ethical shortcomings. Relying solely on the technical operator's subjective assessment without a formal interpretation by a qualified clinician risks misdiagnosis and inappropriate treatment, violating the principle of beneficence and non-maleficence. Delegating interpretation to a physician without specific neurocritical care or TCD training, even if they are a licensed physician, may lead to misinterpretation of subtle findings or failure to recognize critical hemodynamic changes, potentially contravening the ABPN expectations for subspecialty level expertise. Implementing TCD without a clear protocol for interpretation and integration into the patient's care pathway creates a system where findings may be overlooked or misinterpreted, leading to a breakdown in the continuity and quality of care. The professional reasoning process for similar situations should involve a systematic evaluation of new technologies. This includes assessing the evidence base for the technology's utility, developing clear protocols for its use and interpretation, establishing robust training and credentialing pathways for personnel involved, and implementing ongoing quality assurance mechanisms to monitor performance and patient outcomes. When faced with implementing a new diagnostic tool, a neurocritical care physician should advocate for a multidisciplinary approach that involves nursing, radiology, and other relevant specialties to ensure seamless integration and optimal patient benefit, always keeping the APN standards for subspecialty competence in mind. Question 17. Comparative studies suggest that in cases of severe, irreversible brain injury or a patient lacks an advance directive, the ethical and legal framework for surrogate decision-making regarding the withdrawal of life-sustaining treatment is most effectively navigated by which approach? Option A. Continued aggressive life-sustaining treatment as long as the surrogate insists, even if medical futility is clearly established. Honor the family's emotional needs and avoid conflict. Option B. Immediate cessation of all life-sustaining treatments upon the physician's determination of medical futility, irrespective of surrogate input, to prevent further suffering and resource utilization. Option C. A rapid, unilateral decision by the attending physician to withdraw treatment after a brief consultation with the surrogate, prioritizing efficiency and physician autonomy in critical care management. Option D. A comprehensive, multidisciplinary assessment of prognosis and patient values, coupled with empathetic, transparent communication and shared decision-making with the legally recognized surrogate, adhering to hospital policy and relevant state law. The correct answer is D. A comprehensive, multidisciplinary assessment of prognosis and patient values, coupled with empathetic, transparent communication and shared decision-making with the legally recognized surrogate, adhering to hospital policy and relevant state law. Explanation. This scenario presents a profound ethical challenge in neurocritical care, specifically concerning the withdrawal of life-sustaining treatment from a patient with severe, reversible neurological injury and no clear advance directive. The core difficulty lies in balancing the patient's presumed best interests, the family's grief and desire for continued care, and the physician's professional responsibility to provide care that is medically appropriate and ethically sound, all within the framework of U.S. healthcare law and ethical guidelines governing end-of-life decisions. The absence of an advance directive necessitates a complex process of surrogate decision-making, which can be fraught with emotional distress and differing interpretations of the patient's values. The correct approach, which involves a comprehensive multidisciplinary assessment, open and empathetic communication with the surrogate decision-maker, and adherence to established hospital policies and legal precedents for surrogate decision-making, represents best professional practice. This approach prioritizes the patient's dignity and autonomy, as best as can be determined through surrogate interpretation, ensures that decisions are based on the best available medical evidence of prognosis, and respects the legal and ethical rights of the surrogate. It aligns with the principles of beneficence, acting in the patient's best interest, non-maleficence, avoiding harm, and respect for autonomy, even when the patient cannot directly express their wishes. The process is guided by the ethical consensus that treatment should not be continued solely for the sake of prolonging the dying process, when there is no reasonable hope of recovery or meaningful quality of life, and that surrogate decisions should reflect the patient's known values and preferences. An incorrect approach would be to unilaterally withdraw treatment based solely on the physician's assessment of futility, without robust engagement with the surrogate decision-maker. This would represent a failure to respect the surrogate's legal and ethical role in representing the patient's interests and could lead to significant distress and mistrust. Another incorrect approach would be to accede to the surrogate's demand for continued treatment despite overwhelming medical evidence of futility and irreversible brain death, solely to avoid conflict. This would violate the principle of non-maleficence by prolonging suffering and potentially incurring significant costs for care that offers no benefit. It also fails to uphold the physician's duty to provide medically appropriate care and to avoid futile interventions. A third incorrect approach might involve pressuring the surrogate to make a decision quickly without adequate time for them to process information or seek support, which would be ethically insensitive and potentially coercive. Professional decision-making in such complex situations requires a structured, ethical framework. This includes 1. Thorough medical assessment of prognosis and futility by the neurocritical care team. 2. Identification and engagement with the legally recognized surrogate decision-maker. 3. Clear, compassionate, and honest communication about the patient's condition, prognosis, and treatment options. 4. Exploration of the patient's previously expressed values, beliefs, and preferences, even in the absence of a formal advance directive. 5. Consideration of the surrogate's understanding and interpretation of the patient's wishes. 6. Consultation with ethics committees or palliative care specialists when consensus is difficult. And 7. Adherence to hospital policies and relevant state laws governing end-of-life care and surrogate decision-making. Question 18. Governance review demonstrates a neurocritical care team is managing a patient with new-onset focal neurological deficits and altered mental status. The patient is hemodynamically unstable with a platelet count of 40,000/μL and an elevated INR of 2. 5. The team is considering diagnostic interventions to determine the etiology of the neurological deficits. Which of the following diagnostic approaches best balances the need for information with patient safety in this specific clinical context? Option A. Administer intravenous contrast for a CT angiography of the head and neck. Option B. Perform a bedside echocardiogram and transcranial Doppler ultrasound to assess cardiac function and cerebral blood flow. Option C. Initiate empiric broad-spectrum antibiotics for suspected meningitis. Option D. Proceed with a lumbar puncture to obtain cerebrospinal fluid for analysis. The correct answer is B. Perform a bedside echocardiogram and transcranial Doppler ultrasound to assess cardiac function and cerebral blood flow. Explanation. Scenario analysis. This scenario presents a common challenge in neurocritical care, balancing the immediate need for diagnostic information with the potential risks associated with invasive procedures in a critically ill patient. The patient's hemodynamic instability and coagulopathy significantly increase the risk of complications from an invasive diagnostic test, demanding a careful risk-benefit assessment. The neurocritical care team must consider not only the diagnostic yield, but also the potential for iatrogenic harm, which could further destabilize the patient and negatively impact their neurological outcome. Correct approach analysis. The correct approach prioritizes a non-invasive diagnostic strategy that minimizes patient risk while still aiming to gather essential information. In this context, a bedside ultrasound echocardiogram or transcranial Doppler can provide valuable insights into cardiac function, volume status, and cerebral hemodynamics without the risks associated with lumbar puncture or CT angiography. This aligns with the APBIN emphasis on evidence-based practice and patient safety, which are foundational to neurocritical care. The principle of do no harm, non-maleficence, is paramount, and choosing the least invasive effective diagnostic modality is a direct application of this ethical and professional standard. Furthermore, guidelines for neurocritical care emphasize a stepwise approach to diagnostics, starting with less invasive methods. Incorrect approaches analysis. Performing a lumbar puncture without first addressing the coagulopathy or considering less invasive alternatives is a significant regulatory and ethical failure. Lumbar puncture in a patient with impaired coagulation carries a high risk of intracranial hemorrhage or significant bleeding at the puncture site, potentially leading to neurological deterioration or further hemodynamic compromise. This violates the principle of non-maleficence and fails to adhere to best practices for patient safety in neurocritical care. Proceeding directly to CT angiography without a thorough assessment of the patient's renal function and hemodynamic stability is also problematic. CT angiography can provide detailed vascular information. It involves contrast administration, which can be nephrotoxic, and requires patient transport, potentially exacerbating instability. Without a clear indication that non-invasive methods are insufficient and a plan to mitigate contrast-related risks, this approach is premature and potentially harmful. This demonstrates a failure to apply a systematic, risk-stratified diagnostic approach. Initiating empiric treatment for meningitis without obtaining any diagnostic data is a deviation from standard medical practice and regulatory expectations for evidence-based care. While prompt treatment of suspected infections is important, making such a critical decision without any confirmatory or suggestive diagnostic information, especially in a patient with complex comorbidities, can lead to unnecessary antibiotic exposure, masking of underlying conditions, and potential adverse drug reactions. This approach lacks the necessary diagnostic rigor expected in neurocritical care. Professional reasoning. The professional decision-making process in this scenario should involve a multidisciplinary discussion among the neurocritical care team, including physicians, nurses, and potentially radiology or neurology consultants. The team should systematically evaluate the diagnostic question, identify potential causes, and then rank diagnostic modalities based on their potential yield, invasiveness, associated risks, and the patient's current clinical status. A tiered approach, starting with the least invasive and progressing as necessary, guided by the patient's response and evolving clinical picture, is the most appropriate and ethically sound strategy. This ensures that diagnostic interventions are both necessary and safe. Question 19. To address the challenge of a patient presenting with acute onset of ptosis, diplopia, dysphagia, and progressive limb weakness, with objective evidence of declining respiratory effort and vital capacity, what is the most appropriate immediate management strategy to ensure patient safety and optimize the potential for recovery in a neurocritical care setting? Option A. Initiate empiric broad-spectrum antibiotics and await results of cerebrospinal fluid analysis to rule out infectious etiologies before considering airway management. Option B. Administer high-dose corticosteroids and monitor respiratory status closely, deferring definitive airway management until a clear decline in oxygen saturation is observed. Option C. Perform bedside electromyography to confirm neuromuscular junction dysfunction before initiating any invasive airway interventions or specific pharmacological treatments. Option D. Immediate endotracheal intubation and mechanical ventilation, followed by prompt administration of acetylcholinesterase inhibitors and consideration of plasmapheresis or intravenous immunoglobulin. The correct answer is D. Immediate endotracheal intubation and mechanical ventilation, followed by prompt administration of acetylcholinesterase inhibitors and consideration of plasmapheresis or intravenous immunoglobulin. Explanation. Scenario analysis. This scenario presents a professionally challenging situation due to the rapid deterioration of a patient with a suspected neuromuscular emergency, specifically myasthenia gravis crisis. The challenge lies in the need for immediate, accurate diagnosis and intervention, while navigating potential diagnostic uncertainties and the critical nature of respiratory failure. The urgency demands a systematic approach that prioritizes life support and definitive management, balancing the risks of invasive procedures with the potential for rapid decline. Correct approach analysis. The correct approach, which involves immediate intubation and mechanical ventilation, followed by prompt administration of acetylcholinesterase inhibitors and consideration of plasmapheresis or IVIG, represents best professional practice. This aligns with established neurocritical care guidelines and ethical principles of beneficence and non-maleficence. Prompt airway protection and ventilatory support are paramount in preventing anoxic brain injury and death, directly addressing the immediate threat to life. The subsequent initiation of specific treatments for myasthenia gravis crisis targets the underlying pathophysiology, aiming for rapid clinical improvement. This systematic, evidence-based approach ensures patient safety and optimizes outcomes in a time-sensitive emergency. Incorrect approaches analysis. Delaying intubation to await further diagnostic confirmation, such as electromyography (EMG), is a critical regulatory and ethical failure. This approach violates the principle of beneficence by exposing the patient to unnecessary risk of respiratory arrest and subsequent hypoxic brain injury. It also demonstrates a failure to adhere to established clinical guidelines for managing myasthenic crisis, which emphasize prompt airway management. Administering only supportive care without initiating specific treatments for myasthenia gravis, such as acetylcholinesterase inhibitors, represents a failure to provide definitive care. While supportive measures are crucial, they do not address the underlying autoimmune process. This approach could be seen as a breach of professional duty to provide appropriate medical management, potentially leading to prolonged illness and poorer outcomes. Initiating aggressive immunosuppressive therapy without first securing the airway and providing adequate ventilation is also an inappropriate approach. While immunosuppression is a cornerstone of myasthenia gravis treatment, it is not the immediate priority in a crisis. Delaying ventilatory support while initiating immunosuppression could lead to irreversible harm due to hypoxia, representing a failure to prioritize life-sustaining interventions. Professional reasoning. Professionals facing such a scenario must employ a structured decision-making process. This involves rapid assessment of the patient's airway, breathing, and circulation, ABCs, and suspected neuromuscular emergencies with signs of respiratory compromise, The threshold for airway protection should be low. Simultaneously, a working diagnosis should be established based on clinical presentation, and appropriate, evidence-based treatment should be initiated without undue delay. Continuous reassessment of the patient's status is crucial, and a multidisciplinary approach involving neurology, critical care, and respiratory therapy is often essential. Adherence to established protocols and guidelines ensures that patient care is both timely and effective, minimizing the risk of adverse events and optimizing the likelihood of recovery. Question 20. The risk matrix shows a patient with a severe traumatic brain injury exhibiting initial Glasgow Coma Scale scores of 3, with pupillary light reflex absent bilaterally. Given the potential for neuroplasticity and recovery mechanisms, which of the following approaches best guides the management and prognostication of this patient's neurological recovery? Option A. Implement a comprehensive, multidisciplinary rehabilitation program focused on maximizing functional gains, coupled with serial neurological assessments and judicious use of advanced neuroimaging and electrophysiological studies to monitor for evolving signs of recovery and plasticity over weeks to months. Option B. Rely exclusively on the initial GCS score and pupillary examination to determine the extent of brain damage and predict the likelihood of recovery, without further serial assessments or consideration of rehabilitation interventions. Option C. Focus solely on pharmacological interventions to force neuroplasticity, disregarding the need for a comprehensive assessment of the patient's current neurological state and the role of structured rehabilitation. Option D. Provide a definitive prognosis of permanent severe disability within the first 72 hours, based on the initial GCS score and pupillary findings, and counsel the family to focus solely on palliative care. The correct answer is A. Implement a comprehensive, multidisciplinary rehabilitation program focused on maximizing functional gains, coupled with serial neurological assessments and judicious use of advanced neuroimaging and electrophysiological studies to monitor for evolving signs of recovery and plasticity over weeks to months. Explanation. This scenario presents a professional challenge in managing patient expectations and guiding treatment strategies for neuroplasticity and recovery after a severe neurological insult. The physician must balance the potential for recovery with the inherent uncertainties and the patient's and family's desire for definitive prognostication. The core of the challenge lies in translating complex neurobiological concepts into actionable, ethical, and patient-centered care plans, adhering strictly to the standards of practice and ethical guidelines relevant to neurocritical care within the American Board of Psychiatry and Neurology's Subspecialty framework. Correct approach represents best professional practice because it emphasizes a dynamic, evidence-based, and individualized assessment of neuroplasticity and recovery potential. This involves serial neurological examinations, judicious use of neuroimaging and electrophysiological studies, and a multidisciplinary approach to rehabilitation. This aligns with the ethical imperative to provide accurate information, avoid false hope, and engage in shared decision-making, all within the scope of neurocritical care practice as defined by APN guidelines. It prioritizes patient well-being and autonomy by focusing on achievable goals and realistic expectations. An incorrect approach that focuses solely on early, definitive pronouncements of recovery or lack thereof, without considering the evolving nature of neuroplasticity, fails to meet professional standards. This can lead to premature cessation of potentially beneficial therapies or the creation of unrealistic expectations, both of which are ethically problematic and detrimental to patient care. Such an approach may also neglect the importance of multidisciplinary input, a cornerstone of comprehensive neurocritical care. Another incorrect approach might involve over-reliance on a single diagnostic modality or a static interpretation of initial findings, ignoring the inherent plasticity of the brain. This disregards the dynamic processes of recovery that can occur over weeks to months. Ethically, this represents a failure to provide comprehensive care and to adequately inform the patient and family about the full spectrum of potential outcomes and recovery trajectories. A third incorrect approach could be to dismiss the family's concerns or questions about recovery, thereby undermining the therapeutic alliance and failing to uphold the ethical principle of beneficence. Effective communication and empathy are crucial in neurocritical care, and ignoring or minimizing family input is a significant professional and ethical lapse. The professional reasoning process for similar situations should involve a systematic evaluation of the patient's neurological status, consideration of the underlying pathology, and an understanding of the principles of neuroplasticity. This should be followed by open and honest communication with the patient and family, setting realistic goals, and developing a collaborative treatment plan that incorporates rehabilitation and ongoing reassessment. Adherence to APN guidelines for neurocritical care, including ethical considerations and standards of practice, is paramount.